realize that. Thank you so much. So before we jump into Bernie's talk and Cindy's talk, I just also want to acknowledge that I live and work here on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples here in Vancouver, BC. And I'm very grateful to be on this beautiful land here. I'll also share that the funding for this work came from the Health Canada Substance Use and Addictions Program. And so we're very grateful for our funders. We also received in-kind funding from the BCCSU, the University of Victoria, and I'm also very grateful to all of the staff and other supporters and coordinators who helped move this work along and contributed to this guidance document. It's been a project that's been ongoing since around 2021. So it was multiple years of work, and we had a committee as well that we're all very grateful to. So I'll go ahead and share with you what will be presented today. The learning objectives are to understand the impotence for the MAP guidance and a rationale for starting a MAP, understanding the key considerations for operating a MAP, and then also gaining knowledge so that you or your organization has the key information for starting and operating a MAP, given that we've provided operational guidance in the document that we'll be presenting today. So today, Dr. Bernie Pauly will be presenting on the evidence basis first, and then also sharing with you how and why we developed the MAPS operational guidance document. And then we'll turn it over to Cindy to present to you how the Sudbury MAP operates and is implemented. So with that, I'm very excited to turn it over to Bernie.
Thanks so much, Niropa. One of the exciting things about this has been working in such a great partnership between myself and the Canadian Managed Alcohol Program Study at the Canadian Institute for Substance Use Research, in really true partnership with the BC Centre for Substance Use and their leadership on this, which has been phenomenal. I'm a settler. I am currently living on the traditional territories of the Lekwungen people. And so I come to this work really out of a lot of, I would say, humility and learning with the community. And I started in 2011 when Portland Hotel Society actually invited myself and my colleague, Dr. Tim Stockwell, to do the evaluation of one of the first of an early MAP in BC. And this has expanded into what is now the Canadian Managed Alcohol Program Study. So I'm going to share with you a little bit about the evidence base and then a little bit about the development of the program. So next slide. I think this will come as no surprise to many of you on the call, but alcohol is a very costly substance in terms of harms. It's also a very toxic substance, even though it's legal. And in a country of Canada of about 40 million people, it's linked to 7.7% of deaths, so leading cause of death. More than 700,000 ER presentations, 258 per 100,000 hospitalizations. And I just want to highlight that was in the year 2020. And it's costing in terms of health, social justice, and quality of life costs just over 16 billion. And this has been well documented in the Canadian harms and substance use and harms study. Next slide. Those harms, and I'm clearly not going to highlight all of the harms, but are exacerbated when people are without adequate housing or they're living in situations of homelessness. And we see those harms escalate. And to some extent, they're related to unsafe alcohol sources. So people cannot afford beverage alcohol, so they may be using non-beverage alcohol, which has toxic components. unsafe patterns of drinking where people are in cycles of what we call survival drinking, where there's patterns of binge drinking, and also drinking in unsafe settings because they don't have a home where they can relax in their chair and have a glass of wine at the end of the day. They might be in a park or an alley, and many programs across this country started because people were coming to harms in unsafe situations where they were assaulted or subject to violence. And we really have a lack of alcohol harm reduction interventions in the landscape. And that's where, communities really recognize that it was super important to bring an intervention into play that had a harm reduction component for people as part of the continuum of care. Next slide. And you can just advance. Yeah, perfect. Just advances. You can see here some of the programs in Canada. These are mainly programs that we've worked with over the course of time in Canadian Managed Alcohol Program Study, doing the evaluations. I think at the beginning of COVID, we had just around 20 programs, just over 20. And since COVID, there's been a rapid increase in the number of MAPS. And so you can see I've got there 40 plus. There's probably many we don't know about because sometimes they operate under the radar in response to community needs. Next slide. I think a really important point I want to bring across, and this comes from some of our work with MAPS across the country, is that MAPS are not just providing alcohol. They do provide alcohol in safer sources and amounts, but they do a lot more than that. They address this issue of unsafe settings by providing accommodation. Now, that accommodation can be quite wide-ranging in terms of shelters or transitional programs all the way to permanent housing, but people aren't at risk of drinking outside. And the picture of safer settings there is Toronto Seton House, which was one of the very early programs that was established after a coroner's inquest into the freezing deaths of several men because there was no place for them to come inside where they could bring their alcohol. And the recommendation was that there should be a shelter that did that. But there are also, most programs have some kinds of connections to health and social services, particularly connections to primary care for people that often don't have primary care yet have high needs, and social and cultural connections. And this can look like a broad range of things, from sharing meals together to some Indigenous led programs where there are elders on site and opportunities for land-based healing. But across programs, the importance of the social networks that are really part of healing the trauma that people are experiencing. So MAP is a lot more than just the provision of alcohol. Next slide. I'm going to dive into some of the findings, and I love to start with this quote because this was someone who was a participant in one of our early evaluations with Thunder Bay. And I think it articulates so beautifully the kind of stability that someone can find in a MAP to move from hopelessness to hope. They say, "This program has given me hope and allowed me to really think what I want to do with the rest of my life. Because I was not stuck, I guess you could say rock bottom. Going home couldn't get me out of that rock bottom I was in. But since coming here, I know there's a horizon waiting for me." And I think they articulate so beautifully housing, home, and hope. That's the potential of a MAP in terms of a landscape where people are often do not have access to services because of their drinking. Next slide. So I'm going to go through very briefly at a high level some of the research that's been done around MAP outcomes, and it's all in the national guidelines, so you can access it there as well. So people have experienced improved quality of life, a greater sense of personal safety, reconnection to family and community, and without feelings of shame and guilt. And when people contrast MAPS to other forms of substance use services, they often talk about being respected, feeling a sense of trust, and not feeling those sense of shame and guilt. Secondly, significantly fewer self-reported physical and social harms. So this includes fewer seizures, less withdrawal symptoms, less problems with money, fewer legal problems are some of the examples of those harms. So definitely aligned with harm reduction goals. Individuals report they report, but also programs report improvements in housing stability and retention. In other words, we have some programs where people had not been able to maintain any kind of housing for years, and they were able to retain their housing once moving into housing with a MAP, and increased feelings of safety and home. There's a number of studies that look at contact with police. Contact with police is reduced for anywhere from 43 to 51%. And this isn't surprising because people, the police, one example is, police would normally pick people up and take them potentially to stay in the cells or somewhere else, but they can actually, people have a place to go to. So, there doesn't need to be that level of contact with police. Emergency department visits fell by 40 to 47%. And in one study, there was a 93% reduction in emergency service utilization. And that's because people aren't being brought to the emergency because they're now in a program. So much less emergency department utilization. And not surprisingly, reduced hospital admission and time in police custody. And I'll highlight in a minute some of the economic savings. People are drinking less, and particularly drinking less non-beverage alcohol in a much safer setting. So that's just the last point there. Yeah, reduction in alcohol consumption overall and non-beverage alcohol in a safer setting. Next slide. I'm going to highlight a couple things that I think are worth looking at. A lot of the evidence has come from CMAPS, the Canadian Managed Alcohol Study, and this is one example where you can see that people that are long-term in the MAP are drinking 15, if you look at the first red squares, they're drinking about 15 drinks a day, compared to controls who are not in the program at 22 and new MAPs that were at 20 drinks a day. So they're drinking every day, but they're drinking much less overall, which is going to translate into reduced harms. And then similar pattern for non-beverage, you can see in the column, they're drinking much less non-beverage alcohol. Next slide. I think this is a very powerful analysis that our team did around morbidity or mortality and morbidity. And so MAP participants had a lower risk of mortality compared to controls. There was an 8% reduction. But when they were compared, when they were on MAP and when they were off MAP, there was a 63% reduction in their risk of dying. And both of these are significant, that people are less likely to die when they're in the MAP. We've also found in a couple, in this and other studies, of improved liver function when people are in a MAP, and their liver function decreases when they're out of the MAP. And then this study, as I already mentioned, just reinforces the decreasing ER presentations when they're in the MAP compared to off. So clearly a harm reduction role of MAP. Next slide. This is hospital days. You can see here that people not in a MAP have about 20 hospital days per year. When they're compared to people in the MAP, it's about just under 13, the 12.78. And when you compare people who are in the MAP, when they're on the MAP and off the MAP, it's about 10 days. So being in the MAP results in much less hospital days per year. And you can see that it's significant. Those are the little stars there. Next slide. This is what I mentioned in terms so far there's only been one economic costing study, which was done actually quite a while ago, 2016. And it was looking at the Thunder Bay program, which was found that there was a cost savings of $1.09 to $1.21 for every dollar invested in MAP. And this was just with one program. We're just in the process of doing additional costing where the data is pooled, because the hospital data and the police data the hospital data I was showing you is from 5 programs across the country. Next slide. I wanted to highlight this because we've said right from the beginning, MAP fills a gap in care. And this was an analysis that we did with several of the programs across the country. And, you know, without the MAP, what you have is a street-based survival cycle where people are just going round through criminal justice, through shelters and housing, through community arenas, the street arena, healthcare. They're just cycling around between these places. And the tragedy of that is they're not getting the care that they need. So highly costly, but also ineffective. And, you know, there's continuing displacement, survival, and disconnection prior to MAP. Next slide. This shows what happens when you introduce a MAP into the continuum of care. You create a harm reduction program where that's associated with safety, security, connection to self, and reconnection to community that often disrupts this cycle of survival drinking, so people aren't cycling anymore. So this sort of is just a very graphic way of showing how the implementation works. Next slide. Hospital-based MAPs, they're very important for continuity of care. And there is a small body of literature that highlights their efficacy, preventing severe withdrawal, stabilizing drinking, encouraging patients to stay in hospital, and obviously connecting to health and social supports. Next slide. We have 2 really main areas of research that I think are really important looking ahead. Wisdom and learnings from Indigenous-led alcohol harm reduction programs. We've completed initial work in partnership with an Indigenous-led programs, and that's going to be released fairly soon. And outcomes and learnings of cannabis as a harm reduction. And we've been working on the outcomes of introducing cannabis because it's a much less hazardous substances than alcohol and has some capacity to deal with withdrawals. So you can look all of the evidence and research, as well as a ton of webinars, are on our CMAPS site. If you're in the community of practice, well, so happy you're part of the community. And if you're not, you can contact Brittany Graham, and she can probably pop her email into the chat. Okay, next slide. I'm just going to speak very, very briefly to the development of the MAPS guidance. Next slide. So limited access. So why MAPS now? There was really a lot of concerns during COVID about limited access to alcohol during COVID and the increased harms that could result due to that. So, and the challenges of physical isolation if people were in need of alcohol and they weren't able to access treatment. So that brought a lot of attention to the needs for MAP. Next. Clearly, individuals being at a higher risk of withdrawal and transition into treatment programs may not be what they're choosing or may be difficult. Next, increased government. I think I've highlighted this, increased government and policy awareness and support. And then the last one, we had so much requests during COVID for information on how to implement a MAP and the need for kind of a structured outline or frame. And Naropa and I and others at BCCSU actually developed an interim guidance together at the beginning of COVID. And we're very glad to now be developing national guidelines for this. Next slide. So the BC MAPS guidance, that's the interim guidance I just mentioned in 2020, which preceded this. We had a national expert committee that was formed in 2020 and has been the group that has guided the development of the national guidance. BCCSU did an amazing job of conducting the lit review, and now the guidance being published in July 2023. Next slide. So the document, which is very extensive, and it's funny to work on something for so long and then reread it the days just before this national release, and there is just so much information in there, just everything you could want to know kind of about the current state of the problem, principles of care, program implementation, Claire pounding and evaluation. And I think all of you know this, but if you're writing a proposal to get a MAP funded, everything you need is in there to help you with your proposal. Next slide. This is a really important slide because it speaks to what I've been emphasizing all along, is that we have this gap in care for people with severe alcohol use problems and combined with housing inadequacy. And so the MAP is really a complement to other kinds of interventions like screening and brief intervention, withdrawal management, obviously pharmacology and psychosocial interventions, but it's very uniquely developed to meet the needs of a very high-risk population that focuses on harm reduction and is integrated with culture in many programs, obviously housing, community supports, mental health and primary care, and chronic pain management. So a very unique intervention to fill a very important gap. Next slide. This outlines the principles of care, and I think these have evolved and were very thoughtfully done to recognize what we already know, which is that certain populations are disproportionately impacted by the harms of alcohol. And so needing to be very thoughtful around the determinants of health and centering a MAP as, providing for determinants of health, focusing on client-centered care, focusing on wellness and self-directed care. So as the person defines it, which is very aligned with harm reduction goal setting, trauma and violence informed care. I would highlight that, this is, there are so many resources on trauma and violence informed care, and the guidance is a wealth of resources that you can access further. Anti-racist practice, considerations for 2S LGBTQ plus communities, cultural safety and humility. And I just want to highlight here, a lot of MAPs are Western-led as opposed to Indigenous-led. And that's why I highlighted the importance of learning from and evaluating Indigenous-led programs, of which there are actually very few. There's only about 3 that I'm aware of in Canada. There may be more, but 3 that I know about. And of course, a harm reduction orientation and the integration of medical management. Next slide. So MAP can be divided into 5 different types. There's a broad range of programs from peer-led drop-in. There's a beautiful program in the downtown east side called Drinkers Lounge, to drop-in and day programs that might be more clinically led, outreach programs. A lot of the evidence I talked about was generated in housing or shelter-based models, and then inpatient care settings or hospital programs. So, and actually the hospital and community programs are quite important because they need to be continuous so that if people have to go in hospital, they're not discharged. They're not discharged out of a MAP into a hospital without a MAP. Next. Here's the eligibility: alcohol use disorder, high levels of consumption, non-beverage, chronic homelessness, frequent public intoxication, multiple failed attempts at abstinence-based treatment is often common. And there may or may not be frequent use of police and health. We found that sometimes police actually are overlooking this population and not even picking them up anymore. So that may or may not be a criteria appropriate to a program. And now I'm going to turn it over to Cindy. Cindy, over to you for your expertise.
Thank you, Bernie, and thank you for all that. And, it's a good summary of sort of how I'm going to sort of show how Sudbury has put all this into practice. We're going to look to gain better knowledge and to equip you with more of the information that your organization will need to have in order to start operating a MAP program. And I wish I had such a great document back in 2015, 2016, when Sudbury was opening their programs, because I think it's going to be a great resource for everybody to utilize. Next slide. So the key program implementations that we're going to look at, I'm just going to touch briefly on all of them. I could talk for hours, but just to sort of give you an idea, this is just one city with one type of, or two types of MAP programs, but I'm going to look at the stakeholder consultation, the MAP models that we've used, additional elements to the services that we implemented from one model to the other, the consideration of location and space, our process on alcohol storage and security and some considerations, as well as a really important part of staff qualifications and training, which I really think has a lot to do with the success of a MAP program. And then distributions of roles and responsibilities, and then of course our funded and alcohol procurement. Next slide. So I'm going to talk about stakeholder consultation very quickly. I think it's important to ensure that you are having a stakeholder consultation if you are starting a MAP, and including people with lived and living experience to understand what the needs are. In Sudbury, back in 2013, we did a community consultation with 17 stakeholders and included obviously ER, police, EMS, and we established what the trends were, identified the gaps in the services for marginalized individuals, which came to our goals, which was basically needing, creating a MAP, also due to the housing crisis back then even, emergency shelter to get people out of the cold during our cold winters up in Sudbury, and then to transition individuals safely into permanent housing. And again, the community key partners were then involved in sort of understanding and sort of agreeing to see who would be the best organization to sort of facilitate the programming of these areas in collaboration with others. Next, we're going to look at the MAP models. Next slide. So in Canada, Sudbury was actually the sixth MAP in Canada. So as you can see, and that was in 2015 when Sudbury opened their doors. We opened them. The most common sites obviously are that we saw then were the housing first facilities. Unfortunately, Sudbury was not successful in obtaining a location to be able to house a residential program, but with the community consultation identified that even having a drop-in center, low barrier wet shelter was probably the best way to start to try and help those in need. Next slide. So in our day program, we have the clinical model. Our day program really did sort of model what the residential program really wanted to look like, and we really were able to facilitate a lot of this through partners that had the other 5 partners around the country that were in there. We did use a clinical model and continue to use a clinical model, and we did also have the primary substance of alcohol as being the primary reason for using a MAP, knowing that we did have challenges with co-occurring substance use disorders within our population. While still having problems with the problems finding a location, we did use a temporary location for an 8-person housing first facility model, which we transferred some of the individuals in through there. Next slide, please. So this is our drop-in day center that we did open. It started as a day center, and we worked with the University of Victoria and actually did a day program study on the reduction of alcohol use through a CMAPS program. We did have organized intake, so we did have the same 8 people within our programs at one time, so that we were able to really try and focus on the individualized components that the individual needs in terms of the holistic approach of medical, the alcohol provision. Again, Dr. Mike Franklin, who is on this call today, was my mentor and helps me through, facilitating a non-ideal situation in terms of really needing and understanding the importance of what we thought at that time was the housing first model. But really, at this point, we wanted to really choose the important content and really attend to the social determinants of health and provide the best basics that we could for people with alcohol use disorder, poverty, and homelessness in a safe space, and help them find appropriate accommodations. Since it was only a day program, we provided nutritious snacks, meals, access to medical care, recreation, and life skills. At the same time, in that facility, we also ran an emergency shelter. So we shared the space, which sort of was the reason for a lot of for the daytime hours. Next slide. What we did find in that model is that the off-site housing, especially at the end of the month, was a challenge, because when they were off-site, we didn't necessarily were able to see them every day because they got their money. They were able to, they didn't necessarily need our services because they had money to access other forms of alcohol. So we found that we were sort of a little bit behind trying to stabilize sort of by the middle of the month because they had access to their money. Stabilization, 24 hours, not having 24/7 care was really challenging, as we were located in the downtown area and people were really susceptible to their triggers, such as finances, as well as their social circle, and they were very vulnerable during that time that we weren't able to support them. So we really had to really focus a lot of our work on withdrawal management, to make sure that we are looking out for the health and safety of the individuals, as opposed to really being able to move forward with goal setting and life skills, et cetera. Like I said, the hours of operation, it really did leave for a very vulnerable time for the individuals without the support that we had for them. And location, obviously, was downtown, easily accessible by transit system. However, it did, was a congregated area for people who had social supports down there that may not have been as beneficial to them, and would lead them to maybe some unsafe practices, or especially at night when we weren't available for them. Also, one of the other concerns that we had was that we had various participation in medical appointments. Although Dr. Franklin did come on site, a lot of our appointments had to be off site. And again, with people not being there all the time, sometimes they wouldn't be there in the morning for their appointments, or they may show up not feeling well from the night before, or by the time they came for their appointment, they may be under the influence and not able to fully participate in their medical care. So it was a bit of a challenge to try and stabilize their medical care on top of that as well. Also, in the lack of training back in 2017, there wasn't the focus that we have now in the organization with trauma-informed care, Indigenous support, BIPOC community, to be able to really have the full diversity and inclusion, making it fully holistic for everybody in there. And of course, challenges with engagement. Again, I think I had touched on that in terms of really having that self-directed care, because we were really challenged with maintaining their wellness in terms of their physical wellness and detoxification. Next slide, please. So while we still were in the look for a permanent location, the organization had a home that we actually turned into our Housing First CMAPS model for the 8 individuals. And I think this was a very collaborative model, and we were able to really use the people with lived experience who were working in our program to really design the space that really worked for them. There wasn't as much of that in the first in the Kazan study. So it was a great opportunity to have them involved in building their home, sense of pride and ownership. And I think it really developed the core values of the MAP, where we really started to identify and include different services that really made the guiding principles that we're looking at today come to fruition. Next slide, please. So I just want to touch a little bit on the additional elements of service that we did provide from the day program to the drop-in day program to the Housing First model. So next slide, please. And I think one of the biggest things is that we really had that 24-hour support, and we actually had on-site appointment support. So our physician came on site, but we also were able to have, a pharmacy who was really collaborative with us in terms of being able to come and do medication reviews. We also had psychiatry that was coming on site pre-COVID once every 2 weeks, which made a really big difference for compliance for medical appointments and medical stability, but also for them to feel comfortable and in their own home, being able to get the care and feel supported by staff if they needed that support when they were in their appointments. We were also able to do a lot of OTN for intakes and service provisions during COVID, which was as effective as it could be, and we're appreciative for that. We do have a very large catchment area, so if we had people from out of town, it was a really good way for us to be able to, to identify their needs as well, to see if it was a fit for the MAP. We also onboarded Indigenous social worker, which was fantastic and has made a world of difference in the care that is provided in the MAP that we have today. And we also we went to a financial model of financial management, and there is some talk about the financial management in the document. And we really feel that this was sort of a game changer, because individuals were able to do a little bit more budgeting. They were able to be more stable with their alcohol consumption or non-beverage alcohol consumption right from the beginning. So we were able to really monitor and support them in their journey from the beginning to ensure, the costs are covered for the services that they are receiving, but also to support better spending choices, helping them to budget better, and to sort of eliminate binge drinking and increase intoxication, and to make sure that they still had some money to be able to be independent with as well. But that really was a game-changing moment from the day program, because we were really able to support people right from the beginning on setting off their journey in a positive manner. Next slide, please. Location and space. Next slide. So as I had mentioned, we had the drop-in center. So the drop-in center ran from 8 in the morning until 8 at night during the summer months, and during the winter months, and then 10 at night during the summer months. Reason being is that we operated an emergency shelter out of the same location in the nighttime for those people in the downtown core. It served its purpose to be able to be easily accessible. However, like I had mentioned before, there were some downfalls for that. So I think it's really important to look at the consideration between a downtown versus a residential setting. From our perspective and our experience, the residential setting really made the individuals feel more part of a community. They felt more inclusive. They felt more valued. They had more pride and ownership over a real house, as opposed to a larger sort of facility that was multifunctional. So, and it also kind of removed them from those triggers of downtown and maybe their support systems that maybe weren't so supportive in their journey to recovery. So really important to consider. There's always pros and cons to everything, but making sure that there is an outdoor space, a private outdoor space for people to have to call their own is really, really important. Next space. So next we'll talk about alcohol storage and security. And I know that across the programs that I've worked with, it's done very, very differently. And some people make their own alcohol on site. For us, we do purchase it through a winery down in the Niagara, Ontario region. So we do buy it in bulk. It is inventoried and on delivery and daily by the clinical staff. So it is actually stored in a separate area that's restricted so that only our registered staff have access to that. And then they also make sure that there's daily wine allocated in our local dispensary, as all of our staff do alcohol administration. We also have something called alternative alcohol pours, which is if individuals aren't really fancy on the wine that we have, they are able to purchase in consultation with the clinical team their preferred type of alcohol, and we can utilize that, and we lock that up in the dispensary. It's logged and stored, and then it's administered on a prescription basis that is created with the doctor and the individual to make sure that they're getting what they need in a safe manner. Next slide, please. Staff qualifications and training. I think this to me is really one of the biggest factors of really building a really solid team. Obviously, I think it's important that people are coming to work in a MAP or working with marginalized individuals for the right reason. And I think their values have to align with the program, with a MAP for sure, because a lot of times people will come in thinking, not necessarily understanding what harm reduction is, and really not seeing that boundary of how gray that boundary is between uses of alcohol and not use of alcohol when it comes to abstinence versus harm reduction. And I think that can be, that's a really key consideration, that they understand that and have that support. Cultural diversity in staffing model has been great, has been beneficial, and has really shown a lot of inclusion, not only amongst the individuals, but amongst the staff as well, and really learning from each other on the different culture and diversity models that are out there. Obviously, training in addiction and mental health is important. And then one thing to make sure is that you have adequate funding when opening a MAP. So if in doubt, reach for the stars and then hope for a little bit, and then expect a little bit less. But I know when we get down a little bit further, you'll see sort of the costing considerations and funding when it comes to MAP. Next, please. So just some important trainings that I did want to put out there. We did want to put out there ones that we had finally were able to start implementing sort of around the 2018 mark, that have really been effective in the journey of the individuals and support from the staff. Obviously, we talked about the trauma-informed care, mental health first aid, harm reduction versus abstinence, I think is a really big one. I think sometimes people really don't understand what harm reduction means, although it's been around forever. We don't just do harm reduction for alcohol. We also do some cannabis as well, but we also do safe sex supplies. We do safe supplies. So harm reduction across the board is really important in considering when you're working with the individuals that we're doing. Also safe space and inclusion, and person-centered care and language. The language is one thing that is sort of one of the anti-stigma things that you can do to try and advocate for that. And it's the language that we are using when we're talking to individuals. And I think that's really important as well, to making sure that people have that language as well. Next slide. Distributions of roles and responsibilities. Now, obviously, this is just one program, and our roles are very distinctive, but they're also very collaborative, and that's what makes the team at the harm reduction program in Sudbury is so effective. We are consistent of the staff that you see here, and our residential staff, they're there 24 hours a day. They do your activities of daily living, general maintenance of the home, community integration with individuals, life skills support. We moved from a recreation therapist to a life enrichment worker to sort of give for financial purposes, but also for really giving the life skills training and assisting as an avenue of teaching, and then incorporating that into the activities and the recreation activities that they do, we've found has been very beneficial. Addiction specialist, so non-medical, somebody who's working on triggers, coping strategies, and education to individuals around trauma-informed practices, cognitive behavior therapy, and really anger management and different types of strategies that individuals can take and learn while they're going. And then, of course, we have the Indigenous social worker and then our nursing staff. We actually now have a nurse practitioner located in the same building of our location. So we have Dr. Franklin who comes in or is on call, but also is able to go downstairs for some others. Moving on to funding and alcohol. The next slide. So again, ours is based on the number of participants and funded through a few different programs. Knowing that participants who are on social assistance don't have the funds to support adequate lodging costs or basic needs costs, it is very expensive. So we actually have the rent supplement program that does not follow the individual. It stays with the home, but is able to help to cover some of the costs. So just as a thought for you moving forward, but also right now in Ontario, financially, the needs, the social assistance needs aren't there. The organization was actually funding about $500 to $1,000 per person per month to run the program. So just sort of making sure, like I had said, reach for the stars and the moon when you're asking for funding to be able to sort of set yourself up for a little bit more success. Moving on to care planning. So
I just want to jump in really quickly and note the time here.
Yes.
Normally we would save a little bit of this time at the end for a Q&A, but as we haven't gotten any questions yet, I'm going to just say let's go ahead and proceed with care planning. But I want to make sure that we watch the time for everybody.
Yeah, no problems. And I think a lot of this was covered in Bernie's slides. So we should be able to move on with the programming implementations. And I'm just going to touch briefly on how Sudbury has done that. So eligibility, we can go forward. And again, Bernie talked about the eligibility criteria. This is sort of just a division of how we sort of put the eligibility criteria for individuals in terms of what we're looking for. And we did actually revamp this a couple times as we've moved on through the changing needs of the community. So especially health concerns not addressed because of alcohol use is one of them. And then, just the vulnerability of individuals out there as a criteria. In our screening, next slide, please. So screening and assessment. So under the screening and assessment part is kind of sort of very basic. We have referrals that are obviously self-referral, community referral, hospital referral, walk-ins, phones, emails. From then, it will go to an intake where our RN will also sit with our case manager and get a little bit more of a thorough intake, which at point the clinical team, including the physician, will look at it to sort of see, is this something that we would be able to manage in terms of their needs, their complexity, et cetera. And then from there, we'll either decide if we don't have any beds, we'll put them in a waiting period on a wait list, or we'll bring them in on an admission. And if not, if we can't meet their needs, we will look at another means of support to help them. Next, intake procedures and harm reduction education. So our intake, we've really worked on this over the years and have put in a lot of quality improvement initiatives to sort of speed up the process to be able to really meet people where they're at for their harm reduction journey when they're ready. So really taking advantage of knowing that once we have the individual, if they may not have a phone or we may not be able to find them again, we've implemented a trial period to make sure that the fit works without the commitment. We give this 2 weeks, and during that time, it's a time for the observation. So it's a little bit more for get a baseline of the individual, help them with withdrawing, help them to settle into a communal setting, help the other individual set into the communal setting with another individual, and they have the opportunity to see the physician as well as the nurse practitioner. And even if they don't stay, at least we know that some of their medical conditions have or situations have been looked at. And it also it minimizes outside alcohol usage during the stabilization period because they're only allowed to leave the premises with a staff member, just to be able to support their journey from the beginning. And then at the end of that trial period, then we look to see, is it really right? Is it a fit for you? Is it a fit for us through a care conference to move forward with that? So our individual alcohol and managed plan. Yeah, we can go one more. Thank you. Again, person-centered care approach done with the client and the physician and the clinical team. Obviously, safer drinking strategies really try to reduce the amount of non-beverage and outside alcohol use that is being used. We have a medical directive for standardized pour in case we cannot have a pre-consultation with the physician, so that they're able to actually get started right on a pour, and then it's sort of tailored with the physician and the individual as they go. During the stabilization period or trial period, we have PRN pours during the night if they're going through withdrawal symptoms and their vitals are going down. We have a medical directive for a PRN pour. Top-up pours aren't used a lot, but it's encouraging independence for people to be out in the communities when they start to do work, start to maybe go to school, have appointments and going on their own. They'll have a top-up before, and if they've missed a pour for the next hour, they'll get the next top-up on the next hour when they're back. Alternative pours I talked about, that's the unopened alcohol that they can sign in and have on every other dose, and it's calibrated to making sure that it's an equal amount of alcohol content per dose. And then we also have the ability to hold or reduce the pour during safety, and we have a 20-minute observation period so we can assess intoxication levels. And I know there is examples of intoxication scales within the document for everyone to see. Next slide, please. So intervention duration across the continuum. Next slide. So really in the program, it's very person-centered. Nobody is asked to leave if they're complying with the program and safety. They're still working on their goals. We've had some people stay a month. We've had some people come in and out 2 or 3 times. We've had one person there since 2016 who is still there. So it really does vary depending on the person. And we're very fluid in terms of how we work with them and how we manage their success. When they are ready to transition, or if we find that there is a time where, it's maybe not, their readiness isn't there, we will help them through a care conference to sort of set up what does a discharge look like, what does a soft handoff look like, what external partners can we, bring into the picture to help them on their journey after leaving the MAP program. Next slide, please. Last but not least, for care planning is monitoring. And I think this is really important. Obviously, I've talked about the observation period. We have alcohol provision, both programs. We had the 20-minute observation period before each pour and the intoxication assessment. We also do hourly checks on individuals for safety, especially at night. Some individuals at night can be every 4 hours, depending how stable the individual is. And then after the 2-week observation period, we do weekly checks, or we do weekly check-ins, daily check-ins, monthly monitoring of care conferences, And then we do bi-weekly check-ins with the clinician, the physician, the clinician, and the medical team, just in case there's something that we need to address from there. So I just want, so for this, one of the last slides, this is just based on, and we talked, Bernie talked about data. So this is 8 participants. This is from our day program back from 2016, from all of the data from 8 individuals. And so just want to highlight, you know, the EMS calls that they had went down 73% for the related responses due to alcohol. We had 1 individual who went from 71 calls to 2 in a 9-month period. So, you know, even though that's not a 24-hour supported program, it really goes to show that even a day program, a drop-in program, it really is effective. And our hospital, even in the hospital system, the ED presentations, it was an estimated cost savings of about $50,000 in a 9-month period with just operating a D program for 8 individuals. So again, we did what we could do at the time and really saw that there were benefits and knew that going to a housing first model would even continue to give us more benefits. Unfortunately, due to COVID, there weren't anybody around to give us those numbers yet, but I'm sure they'll be able to get them soon. So then the last slide, I just wanted to highlight some of the learnings here, and I've talked about all of them. But I think one of the big ones is that when we see small wins, they're big wins to the individual. So we need to celebrate those small wins. And I think bringing in this document is a big win for us as a community of practice and a community of MAPS. And I'm really happy to have been part of this. And there's great resources in here for everybody to use, and you know, always willing to facilitate questions if there are any at any time. So again, very quick synopsis.
Thank you so very much, Cindy and Bernie, for both of your presentations. I think it's so clear to me how much wisdom you both have and how much detailed knowledge you have about the ins and outs of everything related to MAPS. So I'm very grateful and appreciative for both of you to share your knowledge with us today. And I also just want to make sure folks know that these resources are available on the CMAPS website and our Help with Drinking website. And we will be making a recording available on those sites so that you can refer back to this webinar at a future time. I think we'll just hand it over to question period now. I realize that we're past time. So we'll just spend a few minutes with questions. So I'll turn it over to Delaney.
Hi, everyone. Okay, so we have a question here for Cindy. The question says, for the housing first model for your 8 participants, how do you approach city bylaws, the not in my backyard community mentality to deliver a MAP program residentially?
Yeah, so great question. So that was one of our challenges, the not in my backyard. We actually went through 6 community consultations with various programs that we had, places that we actually had wanted to use. Fortunately for us, we already had that building within that community. But I think one of our big successes that we've done, that the organization did with all residential programs in settings, is to do a open house and a welcome, so that people from the community and from the neighborhood can actually come in and see that it is supported, learn about it, and really sort of, you know, the individuals do the tours and really embrace that, to show that you want to be part of the community and not there to be more of a not in my backyard setting.
Okay,
The community consultations are beneficial to most parts, but sometimes what we found was coming in and we already had the zoning and everything, so that wasn't as big of a deal. But really doing an open house, the barbecue, and welcoming everybody to be really open about who you are and what you're offering, and how you want to be part of the community.
I'm just wondering if there's any other questions from the audience today. Okay. Well, I just want to say another thank you to participants for joining us today, as well as to Cindy and Bernie for all the work that they've done. I will ask Delaney if you could pop up that survey again for all the participants out there. If you could take another minute or two of your time to take the survey for us, that would be very valuable and appreciated for our grant funding reporting obligations. And with that, I think we'll leave that survey open for a few minutes. And I just want to provide another thank you and share my gratitude towards Bernie and Cindy and our other co-chair who wasn't able to join us today, Karine Meador, who was our physician lead, and all of the committee members who contributed to this work over the last 2.5 years. Thank you so much. And thanks for joining us today.